physiology book you would use in the past. I think your undergraduate A&P book, if you still have that, I hope you do. I used mine all the way through PA school. I use it today. We use an area like taught from it, 11. Great place to go if you have that. If you don't, there's so much available online. But there's a ton of information in your review or Access Medicine, but those are so complicated. Some of those, all of those are so complicated that honestly, if you want more detail to help you understand it, then that's the thing to do, because that can clarify things. But I think what you have to do is look back and go, I need to know the parts that function. And so some of that is anatomy, some of it is cell names and this and that. I need to know what are we changing from and to, like from light to electrical stimulus, and where it's going. And that is that kind of neuroanatomy of it. That's important because it really goes to the level of dysfunction that you can see later. And so as you're studying these things, and if you're getting lost in bits and cations, blow the cations straight off, and know the names of cells and things, and what those nerves are, and where they go. Because that is what really goes to function. And so all the things you get tested on, and then again later get tested on for boards, is really about function and disease states. And so as you study, if you can find ways of looking at the material and seeing it objectively that way, what would I need to know about this if I were me? Well, because I'm going to go out there and practice. So what are the really important bits? Teeny details really aren't the most important bits. Now, that doesn't mean that questions aren't detailed. But if you have a real feeling for the function, that's the most important thing. And then that little detailed stuff can kind of fill in as you're sitting there at the test question. Because it's the same way when you're sitting there with a patient. That, you're looking at an overall picture from the back end, no detail. They're telling you, except they're telling you everything. And I have a wart, and I can't breathe real deep, and I can't see anything out of my right eye, or whatever. And you're trying to get rid of the clutter and try to diagnose it. And it's kind of the same thing to start practicing when you're studying, It's what's this part of this that tells the story that I have to take from here. I really think that that's what can help you study too. At least it might keep you focused, which is good. Okay, so we're exciting a hair cell, and I'm hesitant to put this here, but I think it's cute in that it's just a taste of what we're going to talk about in the urinary system. When we get to urology in, I think it's April, May. Love it. So about ions, but super important in the system in terms of really just also writing prescriptions, because how you eliminate drugs and stuff like that gets really important. So here's something, don't freak out on it, don't focus on it too much, but I'm going to say this so that you begin to understand this is how physiology really works in fluids. Okay, so inside that media scala, that wedge, where the basilar membrane forms the floor, and the organ of Corti sits here, and the tectoral membrane rests on top of those hair cells. That is filled with endolymph. The chamber below it and the chamber above it, and then all around it, are filled with paralymph. They have different natures. Paralymph is a little bit like CSF. Endolymph is a little bit like intracellular fluid. They're a little bit different. Their compositions ionically are a little bit different. And all this means is it just helps with the action potentials. Because the environment is a certain flavor of cation, and the intracellular fluid is a certain flavor and composition of ion. And it's because of that polarity crap works. And so the fact that these hair cells, and it's a mechanical deformation too, really, when you open a channel up, it's important that the neighboring fluid has what you need to come through. And so the stereocilia in the hair cell of the organ of Corti, they're up there in the tectoral membrane, and they're really surrounded by endolymph. The base of that cell is really surrounded by paralymph. Don't worry about it. I'm just telling it to you that this cochlea is quite divided for a reason. Why are there those chambers? Because you're really trying to set up gradients within that fluid so that information can be sent. And so here's just a little more information about depolarization with those stereocilia. Those are physical channels. They physically are opened when the stereocilia move, and you can really see how they're linked together and channels will open. They physically open, it just couldn't be cuter. Potassium rushes in, especially that point, and what that will really do is cause calcium channels to open up a little lower in that cell to begin that action potential. Both are cations. It doesn't really matter the flavor. It's just true. And so then you see once the calcium channels have opened, because the stereocilia did their thing, then these vesicles full of neurotransmitter can be released into the synaptic space and received on that cochlear nerve cell foot. And then that will cause depolarization and action potential sent to the brain. So you have a receptor, and you have a way of transmitting that information. For the eye and for the ear, you know the receptor and you know how it's sent. And that's how it functions. And that will be how it dysfunctions. And then there's PA school, and you're done. Might get a little deeper before then, but basically that's it. You just keep jumping through hoops, and then you get out there and talk about feeling weird is when you're in those patient settings, and then you've been sitting in there doing all this stuff, and you have to, hi, I'm going to touch your body now. It's so awkward. You're like, tell me about your bowel movement. They will ruin peanut butter for you. I'm telling you, they will. And all of a sudden, and then you're just like going, oh my God, what am I doing here? And then it'll all coalesce. I'm trying to get the circle of life, keep it going. Okay. And then here's just another picture, because you wanted it. Hyperpolarization. See, if the hair cell deforms this way, the channel's open. It's at rest here, and you can actually hyperpolarize so that it takes more deformation to open it again. So it's just a subtle grading of on and off. You can be off, or you can be really off. And hyperpolarization is just a little more off. It takes more of the deformity. So anyway, mainly depolarization. Look, potassium came in because those were mechanically gated potassium channels. Yes.
I was just wondering from a picture a little bit, or is there a difference between the little bulb, the transmitter bulbs of the inner hair cell and the outer hair cell?
No.
There's not? Okay.
Yeah, you know, there are more outer hair cells than inner hair cells, and it has something to do with recruitment and amplitude and intensity.
Okay.
And I really don't know or care about any more difference in that. But they function similarly. Neurotransmitter is similar because they're going to the same nerve ending. And so a nerve ending really only knows one flavor of neurotransmitter. And then they use the same flavor. And you can't ever find out what flavor. I know that it's been clearly defined what the neurotransmitter is for the auditory system. So it always just says transmitter. Did that answer you? More or less?
Yeah, I was just a little bit confused because on one picture they're different colors, and it says afferent and efferent, like labeled to each of them, and I was wondering if like one is
like kind of antagonizing another.
Okay.
But it doesn't mean the neurotransmitters are different. But it's just about how you process like ganglion cells and stuff. It's about how you turn on and off things and recruit. So, look, neurotransmitter is sent down there to the little cochlear part of the cranial nerve. So just the whole pathway. You just follow sound and go on in. This is a crappy picture. I was just really looking for something different. But anyway, okay. Auditory canal is out there. Pinna catches the sound wave. It's transmitted through the auditory canal to the tympanic membrane. The vibration is amplified and relayed along the three ossicles in the fluid, air-filled middle ear. And then you're trying to transmit that to the inner ear, which is just all filled with fluid. And you do that by this little oval window being portal. And the stapes will tap that information, its vibration, onto this membrane, and there's fluid here. You create a fluid wave that will resonate with at a particular spot along the length of that basal membrane. That will cause mechanical deformation of the stereocilia of the local hair cells. That cell will depolarize. It will release its neurotransmitter to the cochlear nerve ending, which will create an action potential to be sent to the auditory cortex. Now, this picture is showing the stapes knocking on the oval window and this fluid wave moving through, especially this upper chamber. And that fluid wave needs to stop moving at some point. If it passes along the entire length of the basilar membrane and doesn't resonate with the basilar membrane and sort of disappear there, that fluid wave will continue along the cochlea and kind of begin, the oval window will bulge and help to dampen and stop that way. And so this picture kind of shows that there's an arrow, and this other arrow is showing a round window. So that's really mainly the only point of the round window, is to help dissipate sound or wave energy. Let's get to the brain. Baby. Okay, where are we? Left and right auditory cortex. Okay, go down there to the ears, and you see the cochlear division of that nerve kind of heading inferiorly to these cochlear nuclei. There are dorsal and ventral cochlear nuclei. Okay, so I wrote here spiral ganglion because that's another name for the cochlear division when it's actually in the cochlea. To the dorsal and ventral cochlear nuclei, to the inferior colliculus, to the medial geniculate nucleus, and to the auditory cortex. So integration and then sent to the auditory cortex, which is really, you know, it looks like a long way to go because you're going right back there to the temporal lobe. So which geniculate nucleus was it for eyes? It was left. And that's it. That's the auditory pathway to the auditory cortex. And again, you have to have some information from each ear sent to the opposite hemisphere so that you can lateralize sound. Lateralize meaning not just two ears hearing two different things. Or, hey, like some of y'all's ears don't hear anything then. Oh, I'm sorry. Wow, wow, that was so angry. I'm so sorry. No, none of you can hear your mother's voice, you know. But anyway, this lateralization really is occurring here at the level of the inferior colliculus. So at the optic chiasm, where you had decussation of fibers to create lateralization, you have it here in the inferior colliculus. Coral, the inferior colliculus, so that you can have information for both ears. And here's just another picture. You can spend some time looking at this, but just so you can kind of see where this is in terms of the cerebelli and the cerebri. But look, there's the cochlea, and they're going there to the nuclei, up and relaying out. The medial geniculate nucleus, still using the thalamus for a relay station. Oh my God, sound waves. A couple of main things, properties of sound: amplitude and frequency. frequency is how far apart are these waves. Amplitude is how tall are these waves. So frequency is the pitch of the sound. A high frequency is a high pitch, and a low frequency where the waves are far apart is a low pitch. Tone is something else. We don't really apply the word tone to a wave, because sound is a wave, it's a sine wave. The distance between waves is the frequency. The amplitude of the wave is how high it is. We don't apply tone to that. The tone is the quality of the sound, and so two sounds that are the same will have a different tone because there are a variety of frequencies in there. So all sound is mixed frequency. And so the tone of someone's, it's kind of, it's nearly an emotional kind of response. The pleasantness or the tone, the depth, and the quality of the sound isn't something we can define on a wave, but it is something we can distinguish. So there's just a lot of pictures of waves. Wavelength is between waves. Amplitude is how high the thing is. And I don't really know. Long wavelength means less waves and low sound. High frequency is high pitch. And then amplitude really goes to the intensity of the sound. How loud is it? And that's wave physics. Frequency is in megahertz. Amplitude is in why is this left to me? Amplitude is in decibels. So decibel is about how big the sound is, how intense it is. And frequency is hertz. So that when you hear those two things, you know that those are the two ways you describe sound. Decibel. And there's a painful decibel. There's a certain decibel or a loudness, intensity beyond which it's painful. And so normal room noise is about 50 decibels. A restaurant's 80 decibels. And if you hear noise at 90 decibels for a long time, you'll actually have hearing damage or damage. So, I'm just gonna, this is really discussed in your other stuff, but I felt like I didn't know for sure. So anyway, I will just briefly say there is conductive hearing loss where you conduct the sound wave. An interruption in conduction is a conductive hearing loss. So that's typically some sort of blockage. Sensory neural hearing loss is something's going on at the level of the cochlea, and it's generally loss of hair cells. So then you just can't respond to that frequency anymore. And often it's mixed. Or sometimes it's mixed. But who has hearing loss? I think this is really the big one. From ages 0 to 17, 5%. Ages 18 to 44, 23%, 30% up to age 64, and then everyone over 65 have to have hearing loss. So, but it's just from hearing for so long. You've just been hearing a long time. And back then, we didn't use, oh my God, wait, you guys are totally screwed. You use earphones all the time. I was gonna say we didn't put earphones on kids to make them not be able to hear sounds, but what happens when you stick those in your ears? I do it. I'm not saying, damn you, sticking stuff in your ears. I mean, damn us, but when you put that sound, God, I want to know how many decibels that is. Oh, Google that. Not right now. But anyway, you just use your ears a lot. long time, stuff stops working well. Oh, and I don't even have to mention these to you, Weber and Renee. It's all classic testing of hearing with a vibratory fork or tuning fork. Anyway, that's a slide. We're going to skip it. And then I have more here that's not, you don't have, that I just put the definition of these things. I don't even want to talk about it. But it's really about being able to test someone's hearing, and you can tell if it's conductive loss versus neural loss, because you use a pitchfork and you put it on there against bone, and if it's transmitted, you know, you can tell the difference. Anyway, you'll learn about that. Enjoy, by the way. And then you'll use otoscopes to look in people's ears. You will refer people out for audiograms, which is really how you find out where their hearing loss is. People can have hearing aids. They can use sign language. And then there are cochlear implants, which are fascinating, and we're really getting to see a lot of those. So treatment for hearing loss. I just want to mention hearing loss and treatment for hearing loss. Cochlear implants really would only work for people that have cochlear issues, and it wouldn't be anything that would work if you have auditory cortex issues from head injury or stroke, but it helps if someone has a cochlear loss. And you have a transmitter, and you just use bone to transmit to the nerves, basically. It's cute. It's really cool. I love when you see someone with those and you just know their life has changed, you know. And that's all it took. And a few years ago, those were just experimental. They weren't doing them when I was in PA school even. I mean, they were truly experimental, so it's really cool. Oh, okay, now you can hear. Let's have some balance. We're really going to repeat the exact same thing. The way it works for hearing is really the way it works for balance. You just have the structures in different places. But they are mechanoreceptors with stereocelia, that there's deformation, and then that sends information about where you are in space, or rotational movement, or acceleration. So we're in the inner ear for this as well. And the vestibular division of cranial nerve 8 is what receives this information. So look at the inner ear. You have the cochlea. See where the stapes is resting on. Here you don't, all the bone is cut away, so you can't see that. Where the stapes is resting, there's a vestibule, or chamber, and that's where some of the vestibular system is. And the rest of it is out there in the semicircular canals. And they're oriented in planes of, what do you call those planes? XYZ? XYZ? So the vestibular system is about balance. You have another system called proprioception, and there are receptors in joints and muscles that tell you where your arms are in space. Where your body and head are in space is really a function of the vestibular system. So proprioception is really interesting, and that's one of those things like, oh, you know, if you do yoga or whatever, then they'll tell you to close your eyes and you just lose your crap, you know, and fall over, because all of a sudden, you know, you can learn to be better at proprioception by closing your eyes and standing on your toes and stuff like that. But anyway, and people lose it, and it's one of those things you do test for. But we're talking about the auditory and vestibular systems, so it is in the semicircular canals and in the otolithic system that's located in the vestibule. And it's kind of hard to distinguish exactly which one does what, because it's mixed function. All of the information from the system is being sent via the vestibular division, and it's not even really going to any cortex. It's going to cerebellum, brainstem, so that you can right yourself, so that you can, you know where you are, so that you can coordinate your eye and head movements if something's rotating, so that you can watch a moving object and know where you are. Oh, that kind of made me dizzy. But, you know, those are a lot of reflexive things. So you do have a sense of where you are in space that's kind of higher cerebrum, but most of that's going to be correction, cerebellar movement, balance. If you get, you know, you're off balance, you have to correct with muscle, with limb movement and such. So this is really kind of going to a different place. So semicircular canal is really rotational movement, and otolith is gravity and linear acceleration. So if you're moving and then you stop, that kind of thing, so that you know where you are in space. But it really takes all of that information to give it appropriate interpretation. First, semicircular canal, so look at them. Here's the cochlea. It looks so pretty in that color. The vestibule has a utricle and saccule. That's the vestibular system. But let's look at the semicircular canals. There's just a canal now that's filled with fluid. That fluid is called endolymph because it's inside the membrane. And each part of that has an expanded little chamber, and that's called an ampule. So you see an ampule and then a canal, and an ampule, and an ampule and a canal and an ampule. So it has that arrangement. It's quite a simple system, really. The canals are oriented. 2 are at 90 degrees to each other, and a third is in plane X or what, Z, whatever. So you have the canals, the ampulla, and the business part of it, the receptive part, is the crista ampularis, crista or crest of the ampule, or it's also just called crista, because the little tuft of hair cells forms a kind of a crown or crest shape. Same sort of way that it works for hearing. Semicircular canals. The business portion of the semicircular canals is the crista. The business portion for auditory, that's the organ of Corti. The business portion for vision are the photoreceptor cells. So these are really, those are big things to learn. You know, what's the business portion of that? The receptor. So the receptor in the semicircular canals is going to be part of the crista. So let's look a little more detail at it, and I promise we'll get done eventually. Crista ampularis, the receptor structure. It is made up of hair cells. They are mechanoreceptors, just like over there in the cochlea. They synapse with the vestibular division of cranial nerve 8. There are these, I misspelled that on what you have, sustinacular cells, although I won't use that word necessarily again, but it just means a supportive cell. So wherever you see receptors, you see supportive cells. They help. Those receptors are neurons. Neurons don't regenerate. So once those receptors are lost, there is loss. These supportive cells have to be around any neuron to help it to maintain its life, because it's born embryonically and it dies when the body dies. And that's its whole life, unless it dies before that. It doesn't replace. So there's always supportive cells around neural tissue. The hair cells in the crista, in the semicircular canals, synapse with vestibular fibers. And the cupola is the, remember in the, aw, that's cute. Thanks. You're welcome. Let's go back and name the structure then in, what have we done here? Hearing, cochlea, organ of Corti, and there was a gelatinous membrane that those, a little membrane that those stereocilia were stuck in. It was called the tectorial membrane. Okay. In the semicircular canals, those stereocilia are in a membrane. It's called the cupola. So analogous structures in every one of these areas. So nothing's really new here. There's a hair cell. It's got stereocilia. They will deform. And so what happens in the semicircular canals is endolymph, when the stapes knocks on there, there's some fluid movement. But when the whole head moves, you can create a rush or movement of that endolymph through the canals. If it's of such magnitude, it will deform the cupola that weights these hair cells down and deform hair cells. Cations will rush in. That cell will depolarize, and a signal will be sent via synaptic neuron. This cupola membrane just kind of helps weight that down a little bit so that you can have deformation. And you can also have hyperpolarization, and that's information too. Because if you're going one way, you're hyperpolarized, and another way, you're depolarized and sending a signal. And so you have fluid being able to go in a horizontal way, and in a vertical way, and then in this Z way or whatever. And that's how you can know rotational movement, where the head is, how the head is moving. And that really feeds back to eyes, and how your eyes try to locate onto something. They want to focus. They can't see a blurred thing. Your eyes, you know how you're looking out a window when you're driving, and you try to see everything until you can't focus anymore, and then you just blur, and it all goes by. And so, just kind of like this information. So you're able to sense that movement because that fluid is going. And that's all I'm going to say about that. Oh, it isn't. Here's just another little picture. It's just what I just said. So see, there's some movement. You have your little cupola, your little hair cells. That's in the membrane. And look where those crista are located. They're called crista ampullaris because they're located in the ampules. There's not a ton of these, not like the millions of receptors you have in the eye. They sense rotational movements. Movement of the fluid in the semicircular canals rocks the cupola, the cilia depolarize, release of neurotransmitter, action potential cell along the vestibular fibers. That's how that information goes. That's the same thing, you just sort of repeat the same thing. Okay, and the last system. You had the cochlea for auditory system, and then the vestibular and semicircular canal. So we're looking specifically at this sort of otolith part. The semicircular canals had crista. This is a couple of different things, the utricle and the sacula, and each of them will have a macula. And the macula is analogous to the crista or the organ of Corti. Oh, you just stopped listening big time right there. Okay, so look at these two little things in the vestibule. It says otolith organs, utricle and sacule. And in one of them, the macula is oriented horizontally, and in the other one, it's located, it's oriented vertically. And this is how you can sense directional movement, which is what they're supposed to be doing. So the macula is the business portion of that. It has hair cells. There are stereocilia. The difference is there's a kinocilium, a true cilium, around which all the other cilia are oriented. Not much different. And then you have supportive cells as well. But this is cute. The otolith system, and this is the one that's a little bit different. Crista had the cupola. The organ of Corti had the tectoral membrane. And the macula has this otolithic membrane. So again, a gelatinous membrane which will kind of bear down on those stereocilia. But in this case, for the sacule and the utricle, there are otoliths resting on that membrane. And they're like little rocks. They're protein that has been calcified with calcium carbonate. And they weight that down. They weight that membrane down. It causes an inertia, meaning it takes a lot to move that membrane because of that. And that you feel a sense of gravity because of that. And so there's little otoliths resting on the gelatinous layer and really kind of pushing on that layer. So let's say you're running while you're running. You're running away from here like you'll do later. And so this membrane might move back this way a little bit. The weight of it would move it back this way. But you abruptly stop, and you're really going to deform that. So it weights it so you don't move a lot, but once there's a big change, there's a big response as well, because that will shift forward, kind of like those bags in the car. They sense there's like a little ball in a cylinder, and you rotate, but when you hit the end, they'll open up because of that. So it's a little bit like that. You deform. You have a lot of weight here. Anyway, it creates inertia, and it's cute. And you'll see that there's this whole maneuver for trying to get otoliths back in place when somebody's dizzy. So that's kind of an interesting thing. Oh my God, let's get vestibular information to the brain, shall we? Now remember, there isn't a vestibular cortex. What you're mainly trying to do is right the body and keep balance. That's what the whole vestibular thing is supposed to be doing, is balance. So right, left, you're bilateral. And so how do you keep all that balanced? You have to know where you are in space, and the body has to be able to react. So there are these different levels that you get sent to, from the vestibular nuclei to the cerebellum. Cerebellum will send big movements, not fine-tuned movements, but walking, how you walk in that rhythm of walking. That's what the cerebellum does. And you have to know where you are so that you can keep balance while you're walking. That information goes there. There's the nuclei for cranial nerves 3, 4, and 6. And that's really the vestibular ocular reflex, VOR. You were looking at functions of those things, you named them, but you didn't really do functions yet, right? This is where you have to connect vision with balance. So information is sent from the ear, and then there's reflexive to eye ocular movement, for one thing, so that you can see where you are and stay focused when you're moving. That's big. And then also to the reticular formation. And what does that specifically do? Reticular formation. Oh, that's for postural movements. Reticular formation, that's brainstem, and those are postural movements, and it regulates, this is, oh God, you're going to see so much of this. You need to know this. Reticular formation will feed back to the respiratory and cardiovascular system. So you know when you stand up and you get that dizziness, your body has to be able to respond and constrict blood vessels low, push fluid, pull fluid back into the system and so forth. So postural tension and hypotension has to be, you have to know where you are. And if you move suddenly, the body has to respond to that, to move fluid and keep pressures regulated. And then also the spinal cord, lots of reflexes for balance. How you put your arm out if you're going to fall and stuff like that. How you break your wrist when you fall. Those are sudden movements that are really spinal cord reflexes. So this is a great way of understanding how the level to which information rises. The sensory information goes to the cortex, and you see things and you hear things and you relate it to stuff, and then you talk and relate respiration with talking. That's really big. But what about just balance? That doesn't need to rise to the level of you having a voluntary response to that. Although we are aware. And that then goes to the cortex via the thalamus, so that you have this awareness of where you are, or your balance or movement. I simply am going to mention this. Vestibular syndrome, nystagmus, is about this jerk of the eye movement. It's natural. If you're spinning or moving, you try to focus on something and the eyes will have a jerky reaction. If you're at rest and your eyes are jerking, then you have used meth or something else has happened. This is a great way. You've seen it. I know you've seen it. You've seen someone use something and you can see their eyes jerking back and forth. You've seen nystagmus. Or when somebody has been spinning, look at their eyes, some little kid. You know, kids love to spin because it makes you sick like it does when you get older. And their little eyes will be jerking back and forth with you. Just go spin a kid and watch. But it's normal. It's abnormal if it's seen at rest, and so there may be a temporal bone fracture, head injury, stroke, multiple sclerosis, brain tumor, or anti-seizure medications can do it, alcohol, and meth. You will know when you're on your ER rotation. Because they're telling you a story. Their eyes are jerking. And then just briefly, vertigo. I can't not mention this. You're getting diseases, but this is such an important thing because in practice, if you look at all the things that people come into their practitioner, pain is huge, and then dizziness is the other. And so, oh my gosh, dizziness it'll just kill you because there's so many reasons that people can be dizzy. For sure, they can be inner ear issues. So one is called labyrinthitis, and we know where the labyrinth is. It's the inner ear. It's all that business, the cochlea and the semicircular canals. There can be something there, an issue there. And so balance and perception of balance is messed up, so they feel dizzy, lightheaded. And 30% of those are actually viral caused. So there really is illness that can be weighed out. There's something called Meniere's disease, which is this weird, it's called a zebra. You hear about it a lot in school, but I haven't. I mean, I'm not saying you probably know someone that has it or something, but it's an unusual episodic hearing loss and vision disturbance. But they also have pain and fullness in their ears. And the episodes, with each episode, there's some hearing loss at the end of it. So it's a really interesting disease. You can actually have transmission issues at the level of the cranial nerve, and a big example is an acoustic neuroma. There's it's a tumor on the acoustic nerve, and those are not uncommon. They're benign growths on the acoustic nerve, but they can cause a lot of problems. You can even see some facial paralysis as well. But a lot of vertigo won't really be an issue with the inner ear or the cranial nerve. It'll be systemic, so like low blood sugar. You may be a little dizzy right now. Hypotension, low blood pressure, a lot of medications have the side effect of dizziness. And so it is one of the primary complaints. And you rule out ear issue pretty quickly, and then you go from there. What just happened? Again, they have not scheduled me for 4 hours of a lecture again. Because I get excited, I love the information, I want you to hear it and learn it and love it too, and it makes it really hard to love it after so many hours. So when you recover, and whatever that takes for you, Calgon's going to take you away, I know it. You light a candle, you do whatever you do, and just let the bitterness roll off of you, and then just start taking the parts. And so there's an outline, and so you look at the headings and just try to get the big stuff, because right now it's a mushy field of crap, and you don't know where to step. Stop it, and then just start reviewing it a little bit at a time. But it's going to come fast because you only have 2 weeks. But this is how we know we're done. There's Lucille. Aw, she's deaf. Hard luck, Chihuahua. She had a hard life. Can you think of questions that you have for me, or would you just like for me to shut up?